Part 2 of the clinical implications of the musculoskeletal syndrome of menopause. If you haven't watched part 1, go back and watch this. This is clinical applications. What can you do now that you're having all this musculoskeletal joint pain, arthritis, inflammation, sarcopenia, osteoporosis since you're perimenopause, menopause, or postmenopause, going through the menopause transition? And this is from Vonda Wright's article that came out this year. And given the negative implications on women's health, the musculoskeletal system does matter because muscles are a great predictor of your longevity and they do metabolism, they do a ton of things. So we need to care about your muscles. And when you lose muscles, that is called sarcopenia. It is important for both practitioners and patients to know that there are prevention approaches that you can do. This is what I've been talking about as a physical therapist with walking, lifting, vibration plates. So conservative approaches include testing, finding out how bad are you, nutrition and exercise. We want to nourish your body. For instance, in the nutrition realm, you don't process protein as well as you used to. So now I need you to have 1 gram of protein per pound of ideal body weight. For me, that is 141 grams of protein. And I have to be strategic with my 3 meals a day to get that protein in because I want to make muscle. It is so important. So the updated guidelines recommend osteoporosis screening for women age 65 or older and for those aged 50 to 64 who have certain risk factors, including a positive family history of osteoporosis. In a perfect world, I would really love us all to know what our bone density is at 35 because that's where we're at peak bone health with the DEXA scan. But anyway, carrying on. For those aged 50 to 64 who have certain risk factors, including a positive family history of osteoporosis, nutritional vitamin D has been shown to be effective in improving hip bone mineral density in postmenopausal women and reducing the incidence of falls. You can ask to have your D levels checked. You can actually have your serum D checked in your blood. Does insurance cover it? No. Do I have mine checked every 3 months? Yes, I go to CompuNet and I do it. I take 10,000 of vitamin D3 with K2 and a liquid serum, but checking your vitamin D in your blood, then supplementing if you need, although the Endocrine Society came out saying maybe we don't need to do that, but anyway. A recent randomized double-blind placebo-controlled trial investigating isolated vitamin D supplements to bone turnover markers in postmenopausal women aged 50 to 65 with vitamin D deficiency found that 1,000 IU of vitamin D3 for 9 months was associated with reduction in fracture. Surprise, surprise, exercise is perhaps the only non-controversial modality. We've been talking about that. I know you guys know that. And it is, for me as a physical therapist, telling you walking, ground reaction forces, vibration plates, lifting harder than you've lifted, heavy weights. You need to build your bone, you need to build your muscle, and you need to think about being strong. Decreasing estrogen is associated with loss of type 2 muscle fibers and subsequently decreased power, which has been suggested as a primary measure for completing activities of daily living. Along with dietary changes include protein intake and the above mentioned vitamins such as D3 with K2. Resistance exercises may be critical for postmenopausal women to decrease the risk of falls and fractures. Other supplements are currently being investigated. So what I'm saying is, check your D. If your D is low, take D3 with K2. You need to move your body. You need to walk. I need you to do a mobility routine to keep your joints supple and to keep the arthritis at bay. I need you to nourish your body to keep inflammation at bay. I need you to sleep. I need you to not drive it like you stole it. And if I had to pick and you couldn't do anything, walk. Walk. Walking is key. And here's the most controversial thing. Menopause hormone therapy, which is HRT, the new name is menopause hormone therapy, is perhaps the next frontier in the treatment in postmenopausal women in general, and particularly for the musculoskeletal syndrome of menopause. Because estrogen helps you build muscle. Testosterone also helps you build muscle, but I have a hard time selling the idea of testosterone to women. I have a hard time selling the idea of estrogen because people are afraid that estrogen causes cancer, and that's why I talk more about estrogen. I also take testosterone because I am low in testosterone. By slowing the rate of estrogen loss, menopause hormone therapy offers a unique modality to mitigate the potential devastating musculoskeletal effects of estrogen withdrawal and allows for a smooth physiological transition. That's why me, as a physical therapist, talk about hormones and things that you can do because I need you to know the science of your body. You deserve to know. Physicians must be aware of the musculoskeletal syndrome of menopause, communicate the potential role of menopause hormone therapy and lifestyle interventions in their management, and potentially refer them to a specialist who can guide them with these plans. But to tie this up, each woman deserves a conversation about menopause and deserves a clinical evaluation for structural damage and other pathologies that may explain the presenting symptomology. As a physical therapist that specializes in women's health, this is what I do for all my patients, and this is where I walk alongside them, drag them if I must, to get them into the lifestyle modifications that they need to do to optimize their health. These are the things that are non-hormonal changes. I just talk about estrogen because I want you to know. I don't even prescribe estrogen. I just know that it's important for bone and muscle health, and I'm an educator. But what I do prescribe for people is exercise, weightlifting. I help you with your tendonitis. I help you with the self-care of your tendonitis. I help you understand what things that will meet your lifestyle and your physiological needs based on how you're presenting, and your joint pain, and your hip pain, and your glute med tear, and your frozen shoulder, and that chronic tendonitis that doesn't go away, and your low back pain, and your general malaise, and your brain fog, because I am a partner in your team of menopause care, a women's health physical therapist. I know that sounds crazy, but now you get it. Now you see why I talk about what I talk about. Thanks, Fonda. It's an amazing article. It makes me want to cry. Okay, I'm crying.